Thanks very much for the invitation. Wow, I can't believe, okay, first of all, I can't believe the bright light. But secondly, I can't believe that you guys are all sitting here at 5 after 5. So I was asked to give you, in 15 minutes or less, a brief overview about hospital and ventilator-associated pneumonia. For those of you who don't know me, because I can't quite see everybody, Kathy Sue, I'm ID, and I'm at your building fairly frequently, seeing patients. So really what I wanted to do, this is going to be very practical, but just go over the signs and symptoms of pneumonia, differentiate between hospital-associated pneumonia and community-acquired pneumonia, and then just clarify some treatment options and durations for hospital-acquired pneumonia. It's an important problem because it's the second most common hospital-associated infection that we see. Urinary tract infections are much more common, but really in the long run have much lower morbidity and mortality. Ventilator-associated pneumonia is the second most expensive healthcare-associated infection. So in the United States, and this is a modeling study that was just published last year, $44,000 per case, US. The length of stay is clearly increased if you develop healthcare-associated pneumonia or hospital-acquired pneumonia. If you're in the ICU, you have a longer admission to ICU and increased ventilator time. Mortality is high, so studies will say anywhere between about 20 to 50% for patients with ventilator-associated pneumonia. The attributable mortality probably is about 30%, and it is the leading cause of death that is due to hospital or healthcare-associated infections. It's estimated that there are about 4,000 episodes per year in Canada, up to 1,200 deaths, and the overall cost in Canada, these are figures from, I think, around 2010, $46 million per year. The challenge is really that it's quite a difficult diagnosis, and clearly in your population there are coexisting comorbidities that really make the clear diagnosis of hospital-acquired pneumonia difficult. Patients are often on long courses of antibiotics, and I would say longer than they need to be, as we know from recent evidence. So the definition of pneumonia, I think you all know what pneumonia is. It really is lower respiratory tract infection or inflammation involving the alveoli and parenchyma. We use a different number of terms, so you've already heard me say healthcare-associated and hospital-acquired. Community-acquired pneumonia really refers to people who come in with pneumonia, and it's very common for community-acquired pneumonia to be diagnosed in conjunction with congestive heart failure. Pneumonia can precipitate heart failure. Sometimes they can be, it can be just heart failure, but because it's difficult to tell and the chest x-ray is horrible, they get diagnosed with both. Hospital-acquired pneumonia refers to pneumonia that begins after admission to hospital, and by strict definition, it's 48 hours or more after admission to hospital. Sometimes it's difficult to tell because patients may have come in starting with community-acquired pneumonia, but it wasn't really obvious because the main symptom was heart failure, and then they go on to develop a more clear picture of pneumonia, and by our surveillance definitions, we might say that's hospital-acquired. Ventilator-associated pneumonia really requires that you be intubated. Again, onset of symptoms 48 hours or more after intubation. And healthcare-associated pneumonia really refers to pneumonia that patients who have frequent visits to healthcare facilities, for example, dialysis patients, may acquire, or also refers to patients who are in nursing homes or extended care facilities. So really what I'm going to focus on is hospital-acquired pneumonia, patients who come in with something else and then develop pneumonia. To a lesser extent, there will be some reference to ventilator-associated pneumonia in here, but that really deserves its own discussion. So risk factors for hospital-acquired pneumonia. Intubation is clearly the greatest risk factor for developing this, and intubation increases the risk of hospital-acquired pneumonia, which then would be ventilator-associated pneumonia, 6 to 20 times. So it really is the biggest risk factor. What we're doing intubating patients is removing that normal cough reflex that allows a patient to clear their secretions, but also it's allowing potentially a direct conduit from the oropharynx into the lower respiratory tract. You'll see that I put all of the risk factors that apply to your population, right? Age greater than 70 years, chronic underlying lung disease, aspiration obviously is a risk, decreased level of consciousness, which many of your patients have, and chest surgery. Okay. There are a number of risk factors if you look in studies, and I think they're probably the same risk factors that would be applicable to any healthcare-associated infection or bad outcome. H2 blockers have been identified as a risk factor as well. Immune compromise, prior receipt of prior antibiotics, previous hospitalization, prolonged hospitalization, and coming from a long-term care facility typically will increase your risk of having resistant bacteria that are causing pneumonia or, frankly, any other healthcare-associated infection. So the pathogenesis is interesting, and we tend not to really think about this, but it's pretty well documented that being in hospital changes your normal respiratory flora. So we are all, in our healthy states, colonized with bacteria. If I went and took throat swabs from all of you, I would find a variety of organisms, some which may be potentially pathogenic, like strep pneumonia, Haemophilus, Moraxella. Those are organisms that we typically think of when we consider causes of bacterial pneumonia. But then the longer you're in hospital, the more we recognize that your normal flora tend to become co-populated or replaced by more uncommon organisms. So Staph aureus, E. coli, Klebsiella, Pseudomonas. How those actually end up in your oropharynx is something that I don't really fully understand, but it is well documented that that does happen. Pneumonia really is a result of aspiration of oropharyngeal secretions. So whatever your oropharynx is colonized with, you are aspirating those into your lower respiratory tract. And it is it's a normal phenomenon that microaspiration occurs, typically when we're sleeping. And for most of us with normal immune systems and normal cough reflexes and neurologic function, we don't go on to develop pneumonia. Other things that affect the risk of developing pneumonia after this microaspiration includes the microbial load, or how heavily you're colonized in your oropharynx. Host factors, so immune compromise would be the biggest, or the most common example of someone who is more at risk of going on to develop pneumonia. And the virulence of organisms. So some organisms we know are just more pathogenic and more likely to cause disease. Okay. Intubation clearly facilitates aspiration, and that is, again, why it's such a big risk factor. When we look at community-acquired pneumonia, which I'm not focusing on, community-acquired pneumonia, the majority of cases really we don't diagnose a microbial etiology for. Of the cases that we know are bacterial, which is probably about half of all cases of community-acquired pneumonia, the most common organism will be Streptococcus pneumonia, to a lesser extent Haemophilus influenza, Haemophilus parainfluenza, Moraxella, group A strep. Typically, they are one organism, but we know that people are colonized with multiple organisms. When you start to get into hospital-acquired pneumonia and ventilator-associated pneumonia, it's not uncommon to see more than one organism identified on culture. The causes, again, are either the patient's flora or more what they acquire in a colonized state when they're in hospital. Okay, so that is the introduced organisms, depending on the prevalence of resistance in a particular facility or antibiotic pressures. Some of these may be more resistant than others. And then there's some organisms, we don't, thankfully, touch wood, have problems with environmental contamination, like Legionella, for example, but those do occasionally cause problems in hospitalized patients. The diagnosis, I don't think this is new for anyone. Clinical features include a new X-ray infiltrate. So I realize, again, in the majority of cardiac patients, their X-rays are never normal, and it's difficult to determine whether there's a new infiltrate. And two of the following: fever, purulent sputum, or a change in sputum volume is sometimes used, leukocytosis or leukopenia, and we will often say increased oxygen needs. Okay. But if you take the combination of a new X-ray infiltrate and at least two of fever, sputum, or alteration of the white cell count, there is about a 70% correlation with autopsy findings. So if you compare those clinical features with autopsy findings, this is an older study from 1999, 70% sensitivity and 75% specificity. So not great, but that's often all we have to go on. This is a chest x-ray of, she's actually post-op, I can't remember, she just had, I think she just had bypass surgery. But this is somebody who had increased oxygen needs, no fever, and progressive shortness of breath, and a white count that was climbing. So she didn't meet all of the criteria that I just told you. There was no fever, okay? But I think the abnormality on the chest x-ray is pretty obvious. And in fact, her previous x-ray was pretty normal. So to me, this was pretty clear that this woman has pneumonia, and because she'd been in hospital for more than a week, this would be considered to be a hospital-acquired pneumonia. This is a more difficult case, and it's probably more typical of many of the cases that we see. So a 21-year-old woman with a neurodegenerative disorder who's had on and off periodic desaturations with increased oxygen needs and dyspnea throughout her prolonged admission to hospital. She's had some episodes of temporally related vomiting that precedes these episodes of desaturation, no fever, no other symptoms, not including when she's been aspirating, no dyspnea, no white count, feeling fine, no oxygen needs. This is her chest x-ray. So I don't know if anybody is willing to commit to whether or not she might have pneumonia or not based on the x-ray. Yes? No? Can't say. Gosh, that hurt. So this is really what we're faced with, right? So those definitions for diagnosing pneumonia and the criteria with the x-ray findings of a new infiltrate are often very difficult to determine. This was actually interpreted by the radiologist as left lower lobe atelectasis, okay, and really had not changed over a couple of weeks with previous x-rays. Okay. This is her sputum culture. So I don't know if anybody's willing, do you guys look at these? Okay. What I find is that there's often, sorry, I didn't mean that in a, sorry, in a, eek. So what we find is that people often focus on the culture results when they're looking at these, and not the gram stain and not the clinical picture. So if you look at the gram stain, for us in ID, the gram stain tells you a lot of information. So the one thing is that this says few polymorphonuclear leukocytes. Okay? So to me, that suggests that there's not a whole lot of inflammation and is more in keeping with colonization of the respiratory tract. Okay? You can see on the gram stain what they've actually seen. So few gram-negative bacilli, few gram-positive cocci. And on a culture, you get moderate and heavy growth of 3 gram-negative organisms that you wouldn't expect to find in the respiratory tract. But this woman's been in hospital, and so for us, this is not surprising that she'd have Enterobacter, Klebsiella, and Acinetobacter in her sputum. Okay. So based on the clinical picture, the x-ray, which really hasn't changed over 2 weeks, and this sputum culture, she had been started on antibiotics, and I had the opinion that she was actually colonized. Her respiratory tract was quite heavily colonized with gram-negatives, and that she didn't have pneumonia. Okay. It is sometimes a difficult determination to make, but I bring this up only because this is actually a very common culture result in a hospitalized patient, and the gram stain and looking at the white cells can actually give you a lot of useful information. The other thing that commonly happens is that patients will be treated on antibiotics, so if she really did have pneumonia, she'll be started on therapy, and then somebody will repeat a culture because she's still coughing. And we know that treatment for pneumonia reduces the bioburden, leads to clinical improvement, but does not eradicate pathogens from your sputum. So it's very possible that even when she's well, if she gives you a good sputum sample, you may still recover Enterobacter or Klebsiella, but often that is a rationale for extending antibiotic therapy when it's not necessary. So clinical picture is probably key. The key points really are that you can't make the diagnosis of pneumonia without having a chest x-ray. I recognize that it's sometimes difficult to interpret that x-ray. And a chest x-ray that doesn't show an infiltrate does not confirm a diagnosis of pneumonia. So again, it's very common for us to see a diagnosis of pneumonia, but there's not been a chest x-ray done. That may be semantics. The patient may still have needed antibiotics, but just to consider that somebody has pneumonia requires a new infiltrate on a chest x-ray. The gram stain can be very helpful looking at the PMNs, and not all positive cultures require treatment. So for patients who have a low risk for multi-drug resistance, so haven't received repeated courses of antibiotics, haven't been in hospital for prolonged periods, perhaps aren't known to be colonized with resistant Enterobacter or Pseudomonas or Acinetobacter, you can use very straightforward therapy. And what you hopefully recognize from this selection is that these antibiotic choices are all the same antibiotics that we would recommend for community-acquired pneumonia. Ceftriaxone, we would use 1 gram, but if you look in some of the literature, it'll say 1 to 2 grams once a day if the patient needs IV. Levofloxacin is an appropriate alternative. I'm saying levo because that's what we have as our respiratory fluoroquinolone here, and that can be IV or oral. Of course, the caveats with levofloxacin are twofold. One is that if you've received fluoroquinolone for anything in the previous 3 months, there's a higher chance of having fluoroquinolone-resistant flora. The second thing obviously has to do with the QT interval, so you need to look at the EKG before you start them on it. But if a patient is well, so reasonably stable, able to tolerate oral antibiotics, doesn't require IV therapy, you can actually start them on oral therapy, and I've put amoxicillin clavulanate as a good starting antibiotic. If you have a patient who develops pneumonia in hospital, you do not need to add a macrolide. Okay? Macrolides really are targeted towards what we used to call the atypical organisms, Mycoplasma, Legionella, which we don't have a problem with here, and chlamydia. You're not likely to get those in a hospital setting. Azithromycin does not add anything to hospital-acquired pneumonia coverage. And the duration of therapy, really there are a few good studies that have had very good study designs and support that shorter courses of therapy are very appropriate. So we always used to say 10 to 14 days, sometimes 3 weeks, depending what the organism was. Now we know that 8 days is as good as 2 weeks. And if your patient has responded clinically by 8 days, you can stop their therapy after 8 days. If they're not better by 8 days, you need to relook to see if there's a complication from their pneumonia. You might need to extend their course of therapy, but in general, 8 days is adequate. If you have a patient who's at a higher risk for multi-drug resistance or is worsening on your previous empiric therapy, so a lot of the patients here that we see for ID have had repeated courses of multiple different antibiotics. Again, your empiric therapy might include levofloxacin, same caveats as before, piperacillin tazobactam, meropenem as examples. Okay? These are all pretty broad spectrum restricted antibiotics. One of the things that we see a lot here is that I'm going to say on-call pip-tazo is used as a reflex for a lot of things because it has really good coverage for many organisms, but it probably is overkill for the uncomplicated hospital-acquired pneumonia. The one point that I wanted to cover here, we do have MRSA. Obviously, occasionally patients will have MRSA in their sputum. We would recommend adding vancomycin if you know the patient has MRSA. For Pseudomonas and for other gram-negatives, we often are asked the question, is it useful to use combination therapy with 2 antibiotics? And I know that's done a lot, and it's done a lot in critical care units in particular. There isn't actually any evidence that using double coverage improves outcomes. So it might be useful to reduce the bioburden or the microbial load initially, but for the entire course of therapy, you generally do not need double coverage. Just for ventilator-associated pneumonia, for those of you in the CCU, there is the ventilator-associated pneumonia bundle, and really these are preventive measures for ventilator-associated pneumonia. This list of 4 points is really from Safer Healthcare Now. I think that we do have to report ventilator-associated pneumonia from critical care units to the ministry, and so I think that these elements of the bundle have been introduced in the critical care units. Measuring compliance is sometimes an issue, but I wasn't really going to spend a whole lot of time. So again, more key points: ceftriaxone or levofloxacin generally is appropriate. Add Pseudomonas or MRSA coverage if it's needed. No evidence for double coverage routinely. And again, an 8-day course of therapy, and obviously in your patients at this time of year, offer influenza immunization and also pneumococcal vaccine for your patients.